and welcome back to another week of Bulletproof Hygiene. We are excited to have you joining us this week, and we are really enthused and excited to be back again with Tom Viola, our resident pharmacological expert. And today we are talking about anti-anxiety depression medications. Yes. And I feel like this is a really big topic because I know we are seeing these multiple times daily as we are reviewing our medical history. And I wanted to just talk a little bit about prevalence in the United States, because I think this will settle that we're all kind of inundated with this. But according to the ADAA, which is the Anxiety and Depression Association of America, anxiety disorders are the most common mental illness in the US, affecting 40 million adults. That's 19% of the population aged 18 and older every year. And as we know, a lot of these patients are addressing these conditions with the use of medications. And the US Department of Health and Human Services issued a report, and this came out in September of 2020, that during the years 2015 and 2018, 13.2% of adults aged 18 and over used antidepressant medications within the past 30 days. And the use was higher among women, which is 17.7%, than men, which is 8.4%. And then we've got to consider, because that report came out in 2020, and we know that there's been a significant impact from the pandemic on anxiety and depression. So there's definitely been a pandemic effect. And there was a study that came out that showed just during the early stages of the pandemic in February and March of 2020, there was a 21% increase in antidepressant, anti-anxiety, and anti-insomnia prescriptions. There was a report published in JAMA Internal Medicine that estimates 1 in 6 American adults takes at least one psychiatric drug over the course of a year. This report also found that over 80% of those taking these medications reported long-term use, which experts say is concerning since some of the drugs are recommended for shorter use and carry a number of serious risks. So Tom, talk to us. What do we need to know? Because I will say, as I was kind of preparing for this podcast, I was overwhelmed by the number of different drug classifications that are used to address these issues.
Yep, I'm glad, Charissa, you started off with some statistics because, and as you were speaking, as I was hearing you give us the information, I was chomping at the bit to say, don't forget the past 3 years with COVID. But, you know, it's certainly had its effect. I know personally a lot of people who now use anti-anxiety agents and antidepressant agents and hypnotics for sleep more so than ever as a result of that pandemic effect. You know, it's had a great effect on the mental well-being of Americans. And I would also like to say, because we're going to spend a lot of time tonight talking about the different medications, let's not forget that a lot of our patients self-medicate for anxiety with cannabis. I mean, marijuana is a medication that's widely available. It's socially, politically, you know, legally accepted. And a lot of people, especially young people, believe that they can self-medicate for things like anxiety safely with marijuana or cannabis, because at this point cannabis has that acceptance, but also because it's considered natural, especially if it's purchased at a dispensary. And gummies seem innocuous enough, you know, certainly, you know, and so you kind of get that feeling that, okay, they can self-medicate, but maybe they're medicating the symptom, but really not treating the underlying condition. And that's what I think is something I hope that the people listening to this podcast get, that you know, that's that saying, you know, got to walk a mile in somebody's shoes before you get to know them, you know. And that's why in the little time we have at each appointment, we really got to try our best. Not that we're a trained psychologist, but we have to get a sense of their mental status as well as their mental state. You know, what's their approach if they're that anxious about everything else going on in their lives, whatever their burdens are. Going to see a hygienist or a dentist in the office just adds to that anxiety.
True, very true. So one thing that I know we're all so familiar with is hygienists, and, you know, we all learned this in school. And you know, to be honest, I'm 26 years into my career. There's a lot of new medications that weren't out when I was in school. Yeah. So there's a lot of new stuff that we've got to really stay abreast of. But one of the big things we know is, there are a lot of oral manifestations that come with using these types of drugs. So I wanted to make sure we touched on that tonight as far as what we need to be looking for, the conversations we need to have with our patients about that. One of the points that I talked about when I was reading the statistics is a lot of patients take these much longer than was initially indicated. And so, what does that look like to them, down the road?
Yeah, let's break them down by class. Okay, let's break the drugs down by class so it's easier to kind of group them together in our minds. I look at these medications from a 10,000-foot level, okay, and say, okay, the different classes of medications are distinct, but they're sometimes used interchangeably. So when we talk about traditional anti-anxiety agents, in my day, if you're a seasoned pharmacist like me, you remember the days of the barbiturates like phenobarbital and Nembutal and all those drugs, but those drugs are gone now. What we really have are sedative hypnotic agents, which we like to call the benzodiazepines. The more familiar names would be like Valium, Ativan, Xanax, Halcyon, okay? And they're called that because at low doses, they can sedate you, and at higher doses, they can cause a hypnotic effect, meaning sleep reducing. We're very familiar with those drugs in dentistry because we use them all the time. We use them for, pre-op sedation, pre-op anxiolysis, but we also use them in the operatory if we're doing sedation, conscious sedation or minimal oral sedation. So we use the benzodiazepines, and that's why they're so widely used and so common, because they straddle the border between treating anxiety and treating insomnia. But let's not forget, there are true anxiolytics. A drug like Buspar, for example, Buspirone, is specifically for anxiety, has nothing to do or will not treat any insomnia. And on the other side of the coin, we have true hypnotics like drugs like Ambien and Lunesta, which a lot of people are familiar with. And those are true hypnotics. They just designed to help you sleep. But the bottom line is whether our patients are using those drugs for whatever reason, there are specific issues associated with them. So number one, they're not just used for anxiety and insomnia. They could be used to treat seizures. They can be used to treat alcohol withdrawal. So we don't know, and that's why we always go back to that same three questions. Remember, Chris, we talked about it. What do you take? Why do you take it? Did you take it today? We want to know before we jump to conclusions, why they take those medications. Now, I can't say there's real oral manifestations from this class of drugs. I can say, xerostomia for sure, but I could also say more than likely it's sedation. So your patient may be more lethargic in the chair than normal. But what gets a lot of hygienists and dentists a little concerned is the amnesic effect. So these drugs cause what's known as anterograde amnesia, which means, you take the drug and then for the next few hours, you're not writing to the hard drive. Okay, you experience the whole thing, but it's gone all of a sudden, like that Word document you worked on for 8 hours and forgot to save. Okay, that kind of thing. And then there's the notable sleep activities, things like sleep walking, sleep talking, sleep eating, which is what I blame my 2-month pregnancy on. Some people could say otherwise, but that's my excuse. So it may not be a true oral manifestation, but it can affect the quality of life. And as you said, and so aptly put, the folks are using these medications way too long. And the problem is we don't know what the effect on REM sleep is. Some people achieve true REM sleep with these medications. Some people do not. And we don't know the long-term effects on their well-being if they don't achieve REM sleep on a regular basis.
I was curious about that actually, about some of the true hypnotic medications. And you mentioned before, Charissa mentioned before, that a lot of these are designed to use on a short-term basis, but a lot of people end up using them long-term. Can you elaborate any on what studies have shown regarding REM sleep, or is it really just that it's inconclusive? Like some people can achieve REM sleep and some people can't. Is it a higher likelihood that someone will achieve REM sleep? Because if a person is taking this sort of drug, clearly they're having an issue sleeping, so they may not be achieving REM sleep when they're not taking it. But I'm just wondering if it inhibits, or if it's, if it's only designed for short-term use, not long-term use, like what would the outcome for our patients be?
It's a very good question, Brittany. I will tell you that we don't know. It's very idiosyncratic. It's hard to say because it's been inconclusive as to whether or not patients achieve REM sleep, because we don't have patients in sleep studies every night, right? So we don't know on a regular, and that's exactly the point, on a regular basis, taking these medications routinely, we don't know long-term if that affects their REM sleep or not. There have been some studies, but again, most, in my opinion, if I remember correctly, mostly inconclusive. I will tell you that these drugs are, as many people would tell you as well, somewhat habit forming. So there's a certain amount of reliance or dependence on the medication at some point. And I would say, again, without knowing too much about individual responses, some people find it that if they don't take the medication, they get rebound insomnia, where, they try to wean themselves off. They don't take the medication and now they can't sleep at all. So it's a catch-22 for a lot of folks. And I don't blame folks for, taking it every night thinking, well, but I'm going to at least get some sleep. I'd rather get some sleep than none at all.
Mm-hmm.
What is the long-term effect for patients? You mentioned self-medication earlier with cannabis, but I know there's a lot of patients that self-medicate for specifically for sleep with a lot of the Tylenol PMs and a lot of these over-the-counter kind of medications. What are you seeing, or what do you know about the long-term ramifications of relying on something like that?
It's a good question. And that was going to be one of my last points, but I'm glad we talked about it now. Everyone out there thinks, well, let's go with Tylenol PM, Advil PM, Salmonex, Unison. Let's go with the over-the-counter sleep aids because, first of all, there's this idea that they're not habit forming. Second, they wouldn't sell them over the counter if they weren't safe. Again, this is the general consensus, but I always say, well, they sell rat poison over the counter too, so let's not get too far along the walk there. But also, they're considered, safe to take because lots of people take Advil PM or Tylenol PM when they have difficulty sleeping. Now, I'll tell you that sometimes it's not the diphenhydramine in the Tylenol PM or the Advil PM that's actually doing the job, but more likely the Tylenol, the Advil, treating whatever nagging pain is keeping these folks awake. But taking Tylenol PM or Advil PM on a long-term basis, no one's there in the Walgreens or the CVS in the aisle saying, don't take too much of that. So, 1 is good, 2 is better, 3 is freaking awesome. And so people tend to take more thinking, well, they want to get some sleep. But high doses of diphenhydramine can actually cause arrhythmias in some cases. Not in 1 or 2 or 3 capsules, but in very high doses. But for those people that are prone to arrhythmias, I'm not sure I'd want to take, more than maybe 1 or whatever the label recommends you take. What concerns me also is that it's not just diphenhydramine. Doxylamine is also another ingredient that's available over the counter. And again, that's an histamine as well. And then, let's not forget everyone's reliance on natural remedies like melatonin. And I've seen a lot of cases of melatonin toxicity from folks who themselves or give their kids too much melatonin to try to get some sleep. And unfortunately, there's no one there at the health aid store, or again, the Walgreens, CVS, Rite Aid, they don't take too much, melatonin.
Isn't it possible to, like, if you are overdosing yourself on melatonin to cause a depression issue, doesn't it influence like how you feel during the day regarding mood?
Absolutely.
Another issue for people.
Right, Brittany. And that's the thing. So now put that person in a stressful situation, like in the hygienist chair, and that could manifest into behaviors that are inappropriate or, at least unexpected. And let's not forget also that if nothing else happens, maybe they've got daytime drowsiness now because, okay, you can't sleep, right? When do you finally cave in and take the medication? Okay, if you don't take it on a regular basis, you probably take it at like 1 a.m. or 2 a.m. because you're just exhausted and need some sleep. Okay, well, now you'll have a latent effect of that medication, which means in the morning, you've got to drive somewhere, you've got to maybe operate machinery of some kind. So there's a lot of hazards associated with using these medications, which is why they're often prescribed for short-term use only. PRN, if you will.
Yeah, I want to switch over to some of the other types of drugs used. I know beta blockers are one that we see, which tends to block epinephrine response. So one question I had on that front is, for those patients, I would think that's one thing we want to be very mindful when we are using anesthetics on them, because if they've already got something that's blocking epinephrine response, does that play into us using an anesthetic with an epinephrine in it, or is that a different activated response?
Good question, Carissa. So keep in mind, and this is my saying, I've never coined it. I know people use it, they can use it freely, but in my opinion, lately, beta blockers are the new Xanax. A lot of doctors prescribe beta blockers to treat anxiety and treat stress because they're not habit forming and because they have that depressant effect on the cardiovascular system, which has this reflex depressant effect on the central nervous system. Now, in the older days, again, if you're a seasoned veteran like me, you remember the non-selective beta blockers like propranolol, which a lot of women and men still use to treat migraine headache and sometimes tremor, and even sometimes vasovagal issues. But that would be an issue, at least theoretically, because using epinephrine in a patient who's taking a non-selective beta blocker would mean only alpha effect, and that could raise their blood pressure and pulse, although it's really never been seen very often. Most people today use selective beta blockers like metoprolol and atenolol, which really don't have that effect on epinephrine, thank goodness. But on that topic, we should really be talking then about the true antidepressant agents, which are also used as anti-anxiety agents. And some of them are, like tricyclic antidepressants. You've heard of them in the past, you really don't remember what they are. Amitriptyline would be the best example of that, which a lot of people use for migraine headache, neuropathy. Again, what do you take? Why do you take it? You're always asking those questions. But the newer version of those drugs would be what we call the SNRIs, like a drug like venlafaxine or Effexor, which is designed to inhibit the reuptake of both norepinephrine and serotonin in the brain. They also find use in treating other things like neuropathy. So Cymbalta, which is in that same class, duloxetine, would also be useful in treating chronic pain, myofascial pain, fibromyalgia. So again, boy, I can look at 10,000 foot level and put them in little buckets, but it gets blurry as you get closer to sea level because they're used interchangeably for so many things. The more common in that class would be the SSRIs, and they would be things like Lexapro, Prozac, Zoloft, Paxil. Those drugs are serotonin specific, right? They only selectively inhibit the reuptake of serotonin in the brain. But again, that's just serotonin. There are other drugs out there that affect other neurotransmitters. So bupropion, which is familiar to a lot of hygienists because it was used for smoking cessation for quite a while under the brand name Zyban. It's really now sold under just a generic name. And even a drug like trazodone, Deserel, which is used almost exclusively for insomnia now. Here's why I feel for hygienists, though. You're the hygienist. It's been years since pharmacology class. You don't know what this drug trazodone is. You look it up, and the first word that pops out at you from the database is it's an antidepressant. And you're going down this road. And meantime, the patient's using it for something completely different. So that's why it's important to ask the three questions. What my experience has shown me about these medications, though, is number one, they're not just antidepressants, right? They're also anti-anxiety agents. So first things first, we can't assume the patient's dealing with either one, okay? We don't know for sure, we'd have to ask. But we can certainly count on things like central nervous system depression, depending on the drug, sometimes stimulation, depending on the drug. So lots of people who first-time Lexapro users will tell me they can't sleep for days. But the one thing they never fail to mention, because they know I'm somehow involved in dentistry, is, man, I can't stop gritting my teeth, clenching. I do it all day. I don't know why I'm doing it. And that is, so, in the textbook, you're going to see it listed as bruxism. But between you, me, and the lamppost, it's not that, of course. It's clenching mostly during the day. And then these are the folks that end up with things like TMJ issues, right? Myofascial banding, pain, right, in their head. Overdeveloped masseters, so they can't open past the two fingers, so you can't even see what's going on in there, right? Then you've got fractures, cusp fractures, crown fractures, vertical fractures, and they have xerostomia. They need appliances. It's, wow. That's a hygienist's, full plate right there.
What drives that clenching? What is that? What's the chemistry? Do you know what it is about these that drives that?
The only things, the information is sketchy on it. I would say that the information I've read says it has something to do with the level of serotonin in the brain. As serotonin rises in the brain, certain parts of the brain are activated before others.
Did you say that? I'm so sorry. Did you say that that drug is a stimulant? Did you say that Lexapro is?
Yep. In some cases, it can cause difficulty sleeping. Yeah.
That's
Because
interesting.
of that, activating certain parts of the brain in different orders. And that reaches to a even higher level when you realize that because these drugs activate certain parts of the brain in orders that we're not really familiar with in advance, that's one of the reasons why these drugs, ironically, even though they're used to treat depression and anxiety, are likely to cause suicidal ideation in users in the first few weeks of therapy. What more cruel irony could there be? You're taking this medication, you've finally reached out to your doctor, you want to take a drug for your anxiety or your depression, and the first few weeks of therapy, before you see any real benefits, you're dealing with suicidal thoughts. And so this is where I think hygienists, I've said this, you've heard me say it, both of you have heard me say it many times. This is where you save lives, and if I said this before, Charissa, forgive me, but I keep saying it over and over again, be the bartender, right? As a bartender in college, what did I learn? Learn when to listen, learn when to speak, right? Listen. If I've got depressive thoughts that lead to suicidal ideation, if I have anxiety, it leads me to suicidal ideation, like all hope is lost. I may not tell my clergy person, my family members, my close friends, but I might tell someone I don't know very well, but who's willing to listen and who's approachable, like a hygienist. And all you need to do in that situation is when you hear those words, speak, right? In suicide prevention hotline, we give them that. If they're transgender, give them the information for the Trevor Project. Give them the resources they need, because this is your opportunity to save a life. It's happened 3 times in my career, and the one time I didn't listen, I lost somebody. So every time I think about this, I have to say this as many times as I can. Listen to your patients. If they say things that sound like they're going down that road, don't be bashful. Don't withdraw. Push forward, and that's how you could save a life.
Yeah, talk to us about, because I'm sure that all of us have bumped up against this. And I will say, just last week alone, I saw multiple patients that have 5 to 7 medications that they're taking, and 1 to 2 of them are anti-anxiety or antidepressant drugs. Now, like you said, some of them are not necessarily for that purpose, right. But when you start grouping, you've got this mountain of medications that are being taken, and us as hygienists don't always understand the interactions of all of these. And I'm not even sure medical science always thinks that through, but how do we process that information? Again, I know, like you said, to ask the patient, why are you taking this? How long did you take it today? All those questions. But especially when we're starting to see all these oral manifestations, the dry mouth, the clenching, the grinding, and all, we're having all these conversations. What recommendation can we make to patients just to make sure that they are staying balanced and everything is truly healthy and they're not having compounding effects?
Couldn't have said it better. I'm dealing with anxiety. I'm dealing with depression. Again, I don't know that person until I walk a mile in their shoes. I don't know what burdens they carry. On top of that, I have to clenching and issues with, myofascial pain and headaches. And it's cruel. The best thing a hygienist can do in that situation is tell them it's normal. Tell them it's okay. Tell them, I've treated hundreds of patients, and people have this reaction to medications. Talk to your pharmacist, talk to your doctor, talk to me. I'm the hygienist. I'll tell you, that these sort of reactions are normal. Now, I will say that clenching and bruxing, if you want to call it that, are bad enough. But when we start getting into the class of medications that are known as psychotherapeutic agents, and you might have seen things like, Risperdal or Zyprexa or Seroquel or Abilify. These are medications that people take to bump up the efficacy of their antidepressants. Sometimes they are used straight for, schizophrenia, psychosis, bipolar disorder. But keep in mind that those drugs have the tendency to cause what we call, well, everybody calls it something different. I call it extrapyramidal syndrome, okay? Or some people call it dystonic reactions. Basically, it's a loss of motor control, and it's involuntary. and it typically affects small muscle groups like, so my only example, if you will, I can give you, or analogy would be tics, facial tics. Maybe something akin to where someone just tics involuntarily for no reason, or maybe because they do it to relieve some type of tension that's built up in their muscles. Maybe something like Tourette's in a way. But the problem is that is an issue for hygienists, because those dystonic reactions affect the tongue, the jaw, the neck. So patients can spasm, they can spasm their face, spasm their neck, jut their tongue out, or not hold their tongue in position. They can't. It's an involuntary movement. And you're using pretty sharp instruments, and you're counting on the patient to hold still and keep their tongue in one place, and that becomes a challenge for a hygienist using high-speed instruments and carotrons and so on, and that could be dangerous in a patient who has involuntary movements that are unpredictable. Now, that syndrome, as it's called, extrapyramidal syndrome or symptoms, can progress to the point where stop taking the medication, and those symptoms might disappear, but then you're dealing with your original condition being untreated. So a lot of people stay on these medications for years, especially if they find one that works. They're going to stick with that drug no matter what. And it's the same thing with the antidepressant medications. I can tell you about the myofascial banding and the TMJ and all that stuff. I wouldn't waste 1 second in my mind thinking I'm going to tell that patient to stop taking it. If that medication works for them, I'll work around all that other stuff to keep them on their medication. But with psychotherapeutic drugs, that can progress to what we now call tardive dyskinesia, which is where even if you stop the medication, those involuntary movements continue. And that is very troubling for patients because they now don't have a way to stop those facial movements. And think about it, they're dealing with other stresses, they're dealing with other issues, and now they have this too. So here's what I've learned as a pharmacist. When patients have tardive dyskinesia that affects their jaw especially, what do? They chew gum. That's what they do, because that can help mask the symptoms. And so I see, I'm not really looking closely at you, just looks like you're chewing gum, but really you've got this, you've got this facial movement going on. Well, we all know that chewing gum long-term isn't the best for our teeth, right? Especially it can cause more tension in the jaw, more issues. So, and hopefully it's sugar-free gum, or at least it contains xylitol. But I wanted to make everyone aware of that this does happen to patients, and they may not be so willing to come forward and tell you. You'll know it when you're working on them, but they may be embarrassed to mention it.
Yeah, talk to me about what we need to think about for these patients that are taking, kind of these classes across the board when we are preparing for a sedation type appointment.
So, okay, remember that some people take these medications the way they're supposed to because they've been prescribed, and some people take medications like the benzodiazepines recreational. Happens, okay? So my thought process is always this. Number one, again, what do you take, right? Find out what they're taking, whether it be by prescription, recreational use, whatever. Keep in mind that the same drugs that we use for anxiolysis and conscious sedation are the same drugs they may be taking recreationally. They don't mention it. Well, that's a problem, because now you fall into sedation deeper than I would have wanted you to, because I didn't know you were taking the other medication. It may be hard to arouse you now. I may be more concerned about your airway. You've fallen deeper into sedation than really I can handle in an office. So if I'm the dentist in that situation, I'm concerned. But on a slightly different road here, as the hygienist, I think we need to approach this with, if you see a patient taking any one of these medications, you've got to mentally take a step back and say, whatever apparitions, whatever appearance there is of everything from dystonic reactions to clenching it's all normal. It's all normal. You're going to react as if you've seen it a million times. and you're going to encourage them to see the physician to talk about what they might do to change therapy if that's bothering them. Dropping their defenses, keeping it on the level of, I've seen this a million times. That's okay. That doesn't disturb me. Opening up that dialogue with them will help them open up to you and say, yeah, this really bothers me. I'm really embarrassed by it. What can I do? And that's when you encourage them to see the physician, but that doesn't mean any of that stands in the way of you doing your job, which is, providing good care and recommending good hygiene practices when they get home.
Yeah, I kind of make it a point, especially when I've had some patients that have started up. I see Wellbutrin a lot these days, and I'll have a patient, that has switched from like a Prozac to Wellbutrin, and and I ask, how's that working for you? How are you feeling? Does that seem like that's an improvement? Are you noticing any side effects? Do you have any dry mouth? Just kind of checking in on them to make sure, because I feel like it's a lot like blood pressure medication. I see patients that are taking blood pressure medication and they're still ridiculously high, and I first verify, are you actually taking this? And if the answer is yes, I want you to go back and see your physician, because there's a lot of different options out there. It may be that you guys need to adjust the dosage. It may be a different drug works better for you. And I think the same thing in this category as well, is it's okay to check in with our patients and say, hey, is this working well for you? Because if it's not, we don't want, you to keep taking this. It's probably not great for your system. So I like to just check in with them on that too.
Absolutely. The best thing you could possibly do is show concern.
Yes.
I've been in and out of doctor's offices because this time of year for me, it's quiet and it's right between semesters. So this is where I get all my medical care done all at one time. And you get a real dose of, wow, does anybody care? It's almost like you're rushed in, you're rushed out. But when I go to see my hygienist, albeit she is a former student, so maybe, I don't know, maybe I'm getting preferential treatment, or maybe she dislikes the fact that I gave her a C on that paper. I'm not sure exactly, but point is, when I go see her, she treats me better than anyone has ever treated me in healthcare. And that's why I love her so much, because she does everything I would expect and more. But to be honest, every hygienist I've had has done that. I think that's the point.
Yeah.
I would say this, though, when you brought up the drug Wellbutrin, just as one other side note here, keep in mind, it is also used to treat addictions. Everything from gambling to alcohol to sex addiction, you name it. So if you're going to mention it, great, I think you should, but don't be surprised if they're using it to treat an addiction. You may not actually get that answer, and they may not know that that drug they're using for their addiction is also an antidepressant. Now, in the world of the internet, I'm sure a lot of people look this stuff up and they'll probably know it, but if you think it's going in an uncomfortable direction for them, then, at least, like I said, check in with them and see how it's working for them.
Is there anything that we need to be mindful of or know when we are considering what kind of anesthetics to use, local anesthetics in any interactions that we should be aware of?
I love this because, whenever you read this in a textbook or a drug reference, it says, use epinephrine with caution. So what does it mean? You walk in the operatory, like this, like cautiously? I'm being cautious. Stop. What does that mean? Use it with caution. It means, use it, but keep in mind that maybe you should try to keep the doses low, use a higher percentage, like maybe like a 4% articaine or prilocaine with epi, if you're going to use epi, to get a greater anesthetic effect with less epinephrine. There's the point is, epinephrine could be problematic, but not necessarily. And so you can look at it from two perspectives. Okay, I don't want to use too much epi because I heard it could be a problem with a patient taking this medication. Okay, but if you don't use enough epinephrine and the anesthesia is now not profound enough and you cause them pain, that could be bad for them because that could exacerbate their anxiety or their depression. So it really goes both ways. I would say use epinephrine in the amount you're comfortable using and monitor the patient. And if you find that the patient becomes very hypertensive, becomes anxious, they become diaphoretic, then, next time, as long as it's not a medical emergency this time, next time to make a note to yourself and any other hygienist that treats that patient thereafter to, use low dose epinephrine, maybe the 1 to 200,000 dilution now, instead of the 1 to 100,000 dilution. Half as much epi means twice as much anesthesia can be used to get the same effect. So why not? That's the beauty. I'd also like to mention, because we're on that same topic, remember that anti-seizure medications can be used to treat certain central nervous system conditions as well. So a drug like Topamax can be used to treat migraine headache. And a drug like Lamictal can be used to treat mood disorders. A drug like there's even the Depakote. Sorry, I couldn't come up with it. Depakote is used to treat ADHD. So you might say, okay, I'll look at drug up. It's an anti-epilepsy medication. This patient has epilepsy. No, they do not. Again, it's the 3 questions, right? Don't fall into the trap because it's easy, right? What do you take? Why do you take it? Did you take it today? And make sure that you're fully aware, keeping in mind, and the reason I mentioned it is because local anesthetics lower seizure threshold potential. And these drugs can alter seizure threshold as well. Again, not likely because the amount of anesthesia you're going to use in a hygiene appointment is probably not going to be significant enough to have that effect. But patients who don't take their medications the way they're supposed to, who take medications at higher doses than what's recommended for seizures because they're trying to treat something else like migraine headaches, well, they may be at risk for or have a higher potential for a seizure than you might realize. So know your patient means know their medications and use both epinephrine and local anesthesia in as low a dose as possible, but yet enough to achieve that profound effect.
Awesome. Brittany, any other thoughts or questions on your end?
No, I mean, I'm always curious about the long versus short term like effects of using some of these drugs. And I know that we don't make recommendations in regards to these. I don't know. I just think of the REM sleep question, like the difficulty coming off of drugs or switching drugs. And should we be sensitive to that? Should we be asking questions regarding like side effects of switching, like, let's say from one antidepressant to another, or is that kind of out of our scope? Like, should we just be there like as an empathetic listening ear, or like Charissa's question, how is it working for you kind of thing? Like, is it something you think that we should be checking in on as well? Like when someone is switching from one drug to another for the same issue?
Doesn't hurt. As a matter of fact, I think it's great because I think that ultimately the patient, again, every patient's going to be different, but I think in general, a patient hearing you say that would say, wow, you really paid attention to my drug therapy, huh? You really paid attention. You knew that I was taking one drug last time. Even if they don't say it out loud, in their mind, they're thinking, this hygienist knows her stuff or his stuff. They actually paid attention to what medication I was taking. So I think that can't hurt because it adds a certain level of credibility to you as the professional.
Right.
You didn't just say, any change to medications and move right on. Okay, you looked at their medications, you saw there was a change, you mentioned it. I know right now there are hygienists out there doing literally this. I don't have time for that. Totally get it. And if you don't, you don't. But if you can make the time for it, it's going to go a long way in that patient's life and a long way in their impression of you. And overall, it makes you more valuable.
And I think one of the reasons I do ask that is obviously I do care. That's my number one, but also I think unfortunately and kind of unbelievably in the world we live in today, I almost feel like there's still kind of a stigma around taking these kind of medications, and patients can feel like not open to sharing. So I think if you just make it just a very easy conversation that you come across as, hey, supportive. I'm so glad that, that's working well for you. I feel like that opens them up because we know patients come in very guarded. They don't want to give us all the information. They don't think it's relevant anyway. So if we can make that something that we are supportive on, then I think it opens a door for them to be willing to share other things down the road too. And they realize that it all connects, that there's reasons we're asking these things. So I think that they're more open with their information.
Yeah, you've got to have a poker face as a hygienist.
Yes.
You got to be able to look at that person in the eye and say, I've seen that a million times. And that way their guard goes down and they immediately feel like they can connect with you and talk with you. And believe me, that goes such a long way with the patient. I'm still a patient. I will never consider myself a true dental professional. I'm still a patient. And every time I get in the realm of my hygienist or the dentist, if they speak to me like another human being, I immediately, my defenses go down, my guard goes down, I open up and I start talking, and that's when you get the real information. And that's when they see your value. That's when they see that you are indeed a healthcare professional and not just somebody that, unfortunately, people still think you just clean teeth.
Right.
For sure. Well, Tom, do you have anything else, any other pearls of wisdom we need to know on this topic tonight?
all I can say is, again, listen to your patient, treat them like you would they were one of your members of your family. That conveys to them that sense of, wow, this person actually cares about me. That's all your patient needs to love you for the rest of their lives and never want to leave you because you care. So, and I know you do. I know all the hygienists that I know. I see them at meetings. I'm with RDH under one roof, ADHA. Last year, not this year, but every time I walk into a room full of hygienists, I can feel the care in the room. I know they care about their patients. So do it, care. No matter how busy the schedule gets, don't let it get to you. Be that loving, caring person you know you are, and everybody else knows too.
Awesome. Well, those are phenomenal words to leave us with. So I'm going to charge our listeners to care this week and take the time and be the bartender. I love it. I love it. Well, thank you so much for joining us and for your time again, Tom. As always, it was amazing. We appreciate you. And for those of our listeners, we will catch you guys next week. Everyone have a good one. Bye-bye.
Bye.